Hello, this is Miss Kinnan. We are going to talk on pediatric nursing too, with the topic of nursing care on children with mental retardation, autism, ADHD, and Down syndrome. So we are going to talk about mental retardation, autism, ADHD, and Down syndrome. So what's mental retardation? So mental retardations can be called also as intellectual disability, where we have alterations in cognitives, and it's actually where people have a significant limitation on their functional state in intellectual status and adaptive behavior and how they can do things in daily life, and it developed before 18 years old. And intellectual disability actually includes deviations in IQ for less than 70 to 75, and its coexisting deficits into adaptive skills, for example, communication, community use, functional academics, health and safety, home living, leisure, self-care, self-direction, social skills and work, and disability before 18 years old. And the causes is actually unknown, so there must be prenatal errors in the central nervous system which damage to the brain during prenatal, perinatal, or postnatal. It's actually because of exposure to alcohol or other drugs, and there are also motor problems such as hyper or hypotonia, tremor, ataxia, clumsiness, or even visual motor problems. The category for intellectual disability according to severity is divided into four: mild when the IQ is 50 to 70, moderate when the IQ is 35 to 50, and severe when the IQ is 20 to 35, and profound is when the IQ is less than 20. Therapeutic management that can be done is actually provide appropriate educational experiences. We allow the children to achieve level of functioning and self-sufficiency for assistance with minimal support. So we encourage them to do everything by their own with a very limited support so they can function as a normal people. And we can also do a multidisciplinary approach to enhance the child's conceptual, social, practical, and intellectual abilities. The nursing assessment will be that every time they come for screening, we assess their developmental status to see or to identify the developmental delays early. We can also do a health history to determine the mental and adaptive capacities, as well as we took a very detailed pregnancy and birth history, and we also do a sequence in developmental milestones. So the milestone for development in each age, we do it very carefully to see where the children can function, as well as we do a health history for the risk factors such as whether the baby is preterm or postterm, birth with a low birth weight, had a birth injury, whether the baby had a prenatal or neonatal infections, whether the baby had exposure to drugs or alcohol during prenatal, is there any genetic syndrome, any alteration in chromosome, any metabolic diseases, toxins, seizure, orthopedic, speech problems, and even hearing or vision deficit. And we can also do assessment to know if the child was really born with intellectual disability. We can assess the language, the sensory, and psychomotor functioning. We can determine whether the baby is able to go to the bathroom by themselves, the toilet by themselves, dress and feed independently without help or with limited support. And we evaluate their prenatal conditions, whether the baby had a fetal alcohol syndrome. We evaluate the newborn or metabolic screening result and thyroid functions to see whether the growth hormone is taking actions in their thyroid hormone level. And then we can do also CT scan and MRI to see the brain structure, as well as we manage in nursing the child's routine. So we establish the routine with collaboration with the parents, and we stick to the routine, and we ensure that the child has supervision at home. We can also address the frustrations for parents and caregivers to deal with these situations, and we also support the child's function and ability. So we make sure that the child will be able to function normally. And the nursing diagnosis could be delayed growth and development, imbalanced nutrition less than body requirement, self-care deficit for dressing, toileting, and bathing, impaired verbal communication, risk for injury, compromised family coping. And the nursing implementation will be to provide emotional support and information, to maintain a safe environment, and to provide assistance with adaptive functioning. Next is we are going to look at autism. So autism is called autism spectrum disorder or pervasive developmental disorder. So as its name, this is a development and behavioral disorder. So with ASD begin in infant and early childhood, it means that there's an impaired in their social interaction and communications with restrict interest, activity, and behavior. So it can ranges from mild to severe condition, and this might be noticed as developmental delays begin at age 12 to 13 6 months, and then the child then lose previously acquired skills or having a regression in behavior. In the pathophysiology, actually the cause for these conditions is still unknown, but there is a genital makeup, brain abnormalities, altered in chemistry, a virus, or toxic chemicals that cause this. And in the child with autism, the child will display impaired social interaction and communications with preservatives or stereotype behaviors. And the child will have to fail in the development of interpersonal relationship as well as experience social isolation. The child also may have intellectual disability with lifelong supervision, but also some child, they are really gifted in another area of life. Therapeutic management consists of no medications or treatment to cure autism, but we can help the child to reach optimal functioning with the limitations of the disorder. So the treatment will always be individualized because it will based on the behavior and communication therapies, which are essentials for the children to develop a highly structured educational environments. We can also use stimulants to control the hyperactivity. We can use antipsychotic medications for repetitive or aggressive behavior, and we can also use complementary and alternative medicine. In assessment, we can take a health history. We note the delay or regression in developmental skill, such as speech and language abilities. The child may be mute or sometimes only uttering sounds, and maybe also repeat certain words or phrases over and over. And in infant or toddler, there will be spending hours doing the repetitive activity, which demonstrate bizarre motor and stereotypic behavior. As well as an infant, the infant will resist in cuddling, lack of eye contact, be indifferent to touch and affection, and may have changes in facial expression. In autism also, in toddler, they may show hyperactivity, aggression, temper tantrums, self-injury behavior such as head banging and hand biting, hypersensitivity to touch and hypersensitivity to pain, limitations in child's function status such as behavior, nutrition, sleep, speech, language, education needs, and developmental or neurological. In the assessment, we can use the checklist for autism in toddler to really screening if the child have autism. And in physical examination, we can see that the child have lack of eye contact, failure to look at objects, failure to point on himself or herself, failure to address needs, and have a preservative play activities, and unusual behavior such as hand flapping or spinning. And when we assess the head circumference, it will be microcephaly or microcephaly. And in the assessment, we can note the presence of large, prominent, or posteriorly rotated ears. We examine the skin type for hypo or hyperpigmented lesions. We note the asymmetry of nerve function of palsy, hypertonia, hypotonia, alterations in deep tendon reflexes, tall walking, loose gait, or poor coordination. And we can also obtain hearing screening results. Sometimes ascertain that lead screening has been performed because um, lead poisoning can also lead the patients to have autism. And a warning sign for autisms are not babbling until 12 months, not pointing or using gestures by 12 months, not saying a single word by 16 months, not utterances two words by 24 months, and losing social or social skills at any age. Nursing management that we can do is to provide parents with extensive amount of emotional support, professional guidance, and education. We create a treatment plan according to the development of the child, appropriate education, developmental, and behavior treatment program. We then initiate the children to participate in the early intervention program for the child less than 36 months, and we also create a stable routine. We can also enroll the child in a special needs school, as well as ask the parents for the needs of referral and provide positive feedback for the parents. Possible nursing diagnosis will be impaired verbal communication, impaired social interaction, disturbed thought process, risk for injury, risk for caregiver role strain, disabled family coping. Next is the attention deficit hyperactivity disorder. So in an ADHD is the most common mental health disorder diagnosed in childhood. This characterized by inattention, impulsivity, distractibility, and hyperactivity. There are three subtypes such as hyperactivity, impulsive, inattentive, and combined. So a child with ADHD has disruption in learning ability, socialization, and compliance. There will be a high demands on the child as well as the parents, the teachers, and the community. And actually, child may have comorbidity disorder, which means that there are another disorder that accompanying the primary illness, such as deviant disorder, conduct disorder, depression, less severe developmental disorder, auditory processing disorder, learning or reading disabilities. And the pathophysiology, actually exact cause is unidentified. This may relate to the isolation of dopamine and norepinephrine neurotransmitter system. The symptoms can be impulsivity, hyperactivity, inattention that begin before 7 years and last longer than 6 months, cause impaired interactions in social, school, and family at home. And the children with ADHD had frustration, label, mute, emotional outbursts, peer rejection, poor school performance, and even low self-esteem. And sometimes the child also will have poor metacognitive ability, will make the child have poor organization, time management, and unable to break a project into small tasks, and poor skills in this area. With attention deficit hyperactivity disorder, the diagnosis will come from the presence of 6 or more of the following, such as failure to pay attention, careless mistakes on school homework, difficult paying attention to tasks or plays, doesn't listen, doesn't follow through, doesn't complete tasks, doesn't understand instruction, poor organized, avoid dislikes or fails to engage in activities requiring mental effort, loses things needed for task completion, easily distracted and forgetful. For the hyperactivity or impulsivity, they need to be fidgety, squirmy, often out of seat, active inappropriate to situation, can engage in quiet play, always on the go, talk excessively, blurt out answers, has difficulty waiting his or her turn, often interrupts or intrudes on others. With the therapeutic management, what we can do is we provide psychostimulants or non-stimulants norepinephrine uptake inhibitor or alpha agonist antihypertensive agents, which will increase the child's ability to pay attention and decrease the level of impulse behavior. In the behavior therapy and classroom restructuring as therapeutic management plan. For nursing assessment, we did a health history, so we may have a behavioral issues or school performance problem. We ask the history for risk factors and the family history of ADHD. With the physical examination, we screen the hearing and the vision. We observe the child's behavior as well as we note the quickness, agility, fearlessness, desire to touch and explore, observe the adolescents who might have difficulty on staying on task or very frequently to change subject. In laboratory and diagnostic tests, we do a complete blood count and also thyroid hormone levels to see whether there is a problem with the hormonal on the child. With nursing management, we provide patients with emotional support, professional guidelines, and also allow the parents to air concerns for child and the parents. We advocate for the child needs, especially we coordinate with the school system to set a schedule for systematic communications, as well as we teach to use behavioral technique for parents and schools such as timeout, positive reinforcement, reward or prize with withdrawal, and token system. We refer to support groups and we do medication in the morning so we don't have insomnia at night. With the nursing diagnosis, we will might have impaired verbal communication, impaired social interaction, chronic low self-esteem, risk for injury, risk for caregiver role strain, hopelessness, ineffective individual coping, imbalanced nutrition, disturbed thought process, and caregiver role strain. With Down syndrome, what we have is Down syndrome is a trisomy 21, so it means it's a genetic disorder where there's a significant and life-changing and possibly a life-threatening situation. So nurse may face difficulties in approaching the patient, and nurse must advocate also the importance of genetic evaluations and counseling with counselor or physician or even nurse who specialize in genetics, and nurse may provide emotional support as well as referral to agencies, support groups, and resources. Possible nursing diagnosis will be deficit knowledge, decisional conflict, risk for delayed growth and development, fear, interrupted family process. So in Down syndrome, we understand that this is a genetic disorder because the presence of extra 21st chromosome, the most common chromosomal abnormality. So this is actually associated with intellectual disability, where there is a characteristics on facial features and other health problems such as cardiac defect, facial and hearing impairment, intestinal malformation, increased susceptibility to infection. So with the trisomy 21, what happened there is an disjunction or translocation before, at, or after conception, where we receive 23 chromosomes from the mother and 23 chromosomes for the father, but there are 3 chromosomes on number 21, so as you can see here. So with this condition, what therapeutic management we can do, we have to do multiple disciplines collaborations where we need to work together with the pediatrician, physician, cardiologist, ophthalmologist, gastroenterologist, nurse, physical therapist, occupational therapist, speech therapist, dietitians, psychologists, and counselors, even to teachers and parents, so we can really help the children to function at their best. And there are no standard afford treatment to all children with Down syndrome, and there's no prevention or cure, but we can do a treatment that treated the symptoms and become a supportive treatment to promote child's optional growth and development and function within the limit of the condition. And what we do in managing the complications is we provide with the usual immunizations for the child, as well as screening, and we do compilations of Down syndrome. Well, there will be like complications because of Down syndrome related to congenital heart disease, cardiac problem, gastrointestinal problem, as well as vision impairment, hearing impairment, sleep disturbance, thyroid diseases, obesity, atlantoceal instability as unstable on the C2 and C3, acute lymphocytic leukemia, and acute myelogenous leukemia with high risk for infection. So in Down syndrome also we can suggest to do early intervention therapy. So what we do is we provide program and resources for the developmental delay. We provide stimulations and encouragement for children with Down syndrome in a very individualized program. So as you can see here, this is the normal growth and development for the child, but this is the child with Down syndrome. So can you see for sit alone, in normal child it will be around 7 months, but in Down syndrome it will be around 2 months. So there's a delay here in Down syndrome patient. So the nursing assessment, as mentioned before, we took the health history prenatally in perinatal screening. We also assessed the older infant with Down syndrome for any complications such as cardiac problems, hearing or vision impairment, developmental delays, sucking or feeding problems. And we also maybe notice if there are any changes in her physical state. For the physical examination, we will have the physical spatial features for Down syndrome. We observe how the child's general appearance, then lack of muscle tone and loose joint, as well as observe the growth and development, and we see if the child have hearing or vision problem, as well as respiratory and cardiac assessment. So, these are the common sign or common medical clinical manifestation for Down syndrome, such as hypotonia, short statures, flattened occiput, small head, flat facial profile, depressed nasal bridge and small nose, oblique pupillar features, brush-filled spots, low-set ears, abnormally shaped ears, small mouth, protrusions of tongue, arched palate, hands with broad and short figures, single deep transverse, congenital heart defect, short neck, hyperflexibility, dysplastic middle phalanx of the fifth finger, epicanthal, as well as excessive space between large and second toe. So in the laboratory and diagnostic test to divine that this is a Down syndrome, we do ultrasound and blast test on the 11 to 14 weeks, as well as the PAPPA, or pregnancy associated plasma protein A, and then during week 16 to 18 we then continue to do the alpha fetoprotein and the inhibin alpha level to really make sure whether Down syndrome is present or not. And we also do ultrasound amniocentesis for the chromosomal abnormalities. After birth, we can do a chromosome analysis, we do echocardiogram, we do a vision and hearing screening, we do thyroid hormone level, we do cervical radiograph to check about the atlantoaxial instability, and we perform ultrasound. In nursing management, we promote growth and development. Maybe the grow and the learn will be slowly with the shorter attention span, and there will be trouble with listening and judgment as well as developmental milestones. So we need to facilitate the growth and development. We can also prevent complications by educating parents and caregiver on how to prevent complications, as well as promoting nutrition. If the patients have difficulty on sucking and feeding due to poor muscle tone and poor nutritional intake, we can support the chin and throat. And when the patient needs support for education, we can also evaluate the family and the plan of care as a primary caregiver, so we conditions that the family will be able to deal with this lifelong disorder and the continuous health problems that might arise during life. So this is our just a supplemental figure on what to check on Down syndrome child during their visit according to age. 1 month and 1 month to 1 year, 1 year to 5 year, 5 year to 12 years, and 12 to 21st year. So we need to really make sure what capabilities the child has with Down syndrome. So there are also 6 videos that I put that you can go and watch. So I hope that you will have time to watch the video and to let me know what to um, understand about the condition. So the takeaways for this class is that mental retardation can be called also intellectual disability with IQ level low, less than 70 to 75, unknown cause of it. With autism, we have an impaired social interactions and communication with restricted interest, activity, and behavior, also with unknown cause. And ADHD, we have inattention, impulsivity, distractibility, and hyperactivity on the patients, also with unknown cause. And in Down syndrome, we have intellectual disability characteristic on facial features and other health problems, probably with caused by the presence of extra 21st chromosome. And the possible nursing diagnosis will be deficit knowledge, decisional conflict, risk for delayed growth and development, fear, interactive family process, and caregiver royal state. So that are the materials for this week. Happy learning!